Good evening, everyone, and welcome to tonight's webinar. So tonight, Sensible Money's founder and CEO, Dana Anspach, and her guests, experts, will walk us through planning for healthcare costs in retirement. Dana, as many of you know, is one of the nation's leading authorities on retirement planning and decumulation planning, and Sensible Money, which she founded in 2011, was last year named one of Inc. 5000's fastest growing privately owned companies in the country. Dana is the author of Control Your Retirement Destiny, the popular guide to decumulation planning. You can also find this guide as a podcast on Apple, Spotify, and iTunes. Her popular online course, How to Plan for the Perfect Retirement, is available at thegreatcourses.com and wonderum.com. And so with that, Dana, let's get started.
Well, hi, Bob, and hi, everybody. As Bob introduced me, this is normally what we have on screen, and I want to take a minute and introduce our guests who have been so gracious to join us tonight. So we have with us Mike Smith and Derek Cooper from ASC Insurance. They are both insurance brokers, and Derek embarked on his insurance journey first by implementing wellness initiatives for municipalities. So he primarily worked here in Arizona in the large group health insurance space. He saw some of the unique challenges that individuals face when making their health insurance decisions, and so he chose to found ASC Insurance to help both individuals and businesses with their needs. ASC then gained further momentum when Mike Smith joined them, and Mike's journey into this space was very personal. So he witnessed firsthand his father's battle with kidney failure and helped him navigate his way through all of the labyrinth of Medicare and all of the associated insurance plans that go with it. And through this experience, he realized how challenging that can be, how much help and hand-holding people need, and it really inspired him to make a difference. And then Nicole Gurley, she founded Gurley Long-Term Care Insurance in 2001, and I met her shortly thereafter. I believe Nicole and I have been working together for over 20 years now. She is licensed throughout the country, holds what's called a CLTC, a certification in long-term care, and she earned a Bachelor of Arts in Management. She is the past president and chair of the Financial Planning Association of Greater Phoenix and a former host of Money Radio's Planning Past 50. It's more than just your money. So I am absolutely delighted. This is our first webinar where we have had guests join us, and delighted to have these three experts here tonight to share their wealth of knowledge. It's really going to help all of us make better decisions, not only for ourselves personally, but I know we have a large financial advisor following, and it helps all of us help our clients better navigate these decisions when we come across them. So as usual, I have to start with disclosures. So while these are up on the screen, I will remind everybody that nothing we say tonight should be considered personal advice for your situation. As many of you know, at the end, we do open it up to questions and answers, and we often get very detailed questions where people share very specific things. We, of course, address those anonymously. We'll never read off your name when you ask a question, so feel free to ask away. At the same time, we can't give you specific advice. So when we get to the Q&A, we're going to do our best to give you guidance. Here's the things you might want to consider. Here's the pros and cons. Here's what would apply if your situation was X, Y, or Z. But you are always encouraged to meet with your own advisors who can ask all of the thorough questions they would need to ask to give you appropriate advice. So now that we are through the disclosures, let's get started. We are going to be talking tonight about three distinct phases of healthcare. First, there is the pre-age 65 phase. And we make that distinction because if you're going to be eligible for Medicare through working and paying in enough to the system here in the US, then Medicare for most people begins at age 65. Now, it doesn't always have to. We'll be covering that. So if you're still working, wondering if you should be on Medicare yet, we will be addressing that specific issue. And then long-term care is a special form of care that Nicole will be talking about with us, and she'll help us make the distinction between medical care and long-term care. And it usually shows up later in life, but not always. There are situations where injuries or illnesses can cause long-term care to show up much earlier than we might think. Now, sometimes these phases are referred to in the financial planning community, and I certainly refer to them this way, sort of tongue-in-cheek, as the go-go years, the slow-go years, and the no-go years. Now, slow-go years hopefully don't start at 65. Hopefully the slow-go years start a little later than that. We typically see people slow down sometime in their mid-70s, where they may not be traveling as much or eating out as much, but you will hear those distinct phrases applied sometimes to these areas. So we're going to start by talking about pre-age 65, or what should still be the go-go years, and particularly what happens when you want to retire before you're Medicare eligible. How does insurance work? What are your options at this phase? So when we think of this phase, Mike, I'm going to ask you this question, because we get asked this question all the time. And I know in talking with you, you have a distinct framework that you follow when you're helping guide people through the decisions at this point. Can you walk us through what that looks like?
Sure, absolutely. So basically, obviously, you're going to be working to some point. I help a lot of individuals that retire maybe in their mid-50s. So they have a little bit of a gap before Medicare. I kind of follow this list, options 1 through 5. If you have some sort of employer coverage, that's probably a pretty good bet. It's not always the best fit, but usually it is, mostly because your employer is going to be subsidizing that healthcare pretty heavily. A lot of those are pretty robust plans with extensive networks. So I always encourage people, if you have that option, look at it. Where a lot of people start to kind of get confused is, okay, now I've left work, I was let go, something has changed in my life. So you'll have a COBRA option. And basically what that is it's just going to extend your employer-based coverage to you personally through a third-party administrator, meaning you get to keep your work insurance even though you're no longer working for the company. A lot of times this is kind of a costly figure. Technically, it's 102% of whatever your employer was paying on your behalf. So if it's $1,000, let's just call it $1,020 is what you're going to pay for the insurance. When you were working, it probably only cost you maybe 500 bucks. So a lot of people, maybe sometimes that is a good option. So we would like to explore it if that's what you're faced with. The other thing that you can do is immediately after that, if your income is now lower, I like to look at the Affordable Care Act plans, and that's basically through healthcare.gov or the marketplace, or Obamacare as it's sometimes called. With that system, you can actually gain some pretty healthy tax subsidies to help offset the premium dollars that you pay. Another good feature of that is it doesn't exclude any pre-existing conditions or anything like that. So it's pretty much an option for anybody to take when your employer insurance is over. If that is something that maybe isn't a good fit, mostly due to maybe elevated levels of income, something like that, there are other off-exchange options that you can have through individual plans. A lot of these are underwritten types of coverage. They can last a certain term, as many as a few months or maybe 3 years. There's all sorts of layering that can be done here, where basically you maybe assign some fixed benefits to yourself. So you get an allowance to go to the doctor, something like that, and then you get some wraparound coverage. So if true catastrophe strikes, you're going to be very well taken care of. But downside to that is it's going to probably have some underwriting involved. If you have a complex health situation, that might not be a good fit for you. And we want to make sure we're being mindful of that. After that, as kind of a last resort, I would look at maybe some alternative plans. I don't personally deal in these plans, but they're gaining some momentum. Some of the health sharing or the Christian Health Ministries types of plans, they're all over. So those can be an option. I always like to encourage everybody, as with any other insurance company, these are not true insurance plans. So you want to be very mindful of what the limitations, any exclusions, what it does and doesn't cover, and more importantly, what the coverage is capped at. I've seen them as low as $500,000 up to maybe $1 million, but there's no guarantee that any of this is going to be paid. So you just kind of want to really explore the literature that you're being handed when exploring that option, and make sure it's a good fit for you if you find yourself there.
Interesting. So, Mike, there's one thing I heard that I don't hear a lot, and that was option 4. And let me see if I heard you correctly. It sounds like if somebody was healthy and maybe they just had 4 or 5 months, they weren't 65 yet, and so Medicare hadn't started, but they were looking for maybe a temporary, plan to just get them through that gap, and they didn't want to go on one of the exchange plans, that might be an option for them.
Yes, absolutely. Fundamentally, a lot of these plans started as just gap insurance. To be completely transparent, I myself use it as my primary form of insurance. I write it for a year-long term so that if I have to re-up it at the end of the year, if something changes in my health, I know I'm going to be covered for that year, and then I'll be able to roll on to an ACA plan so that my now pre-existing conditions would be covered. But what that gives you is a lot of those plans have a more robust PPO network. So you get access to, national facilities, things like that. And again, it's a lot cheaper than the base level premiums of the Affordable Care Act. So just things to consider there.
Very interesting. That's a great option to have available, because speaking of costs, that's our next slide. And so this came out of I believe a Forbes article, just estimating the average monthly cost for an ACA marketplace plan. Is this in line with what you see?
Yes, it's pretty close depending on the state that you're in. You can see that, and then you have your choices. I mean, there's several plans available, but yes, just as a retail cost with those plans, that seems to be very accurate, especially as you get closer to the higher figures. Maybe you're looking at some more robust gold plans or perhaps a platinum plan. But remember, as long as your modified adjusted gross income is a little bit lower than it has been in the past, you're going to be able to offset that with some subsidies to get some help.
Yeah, and let's talk a little bit about that. Well, there's two things I want to bring up. First, if somebody's retiring, let's say in their mid 50s, we see this all the time. Like here, you have a couple age 50 at $1,300 a month. We've definitely seen people paying $2,000 a month. Now they're in their mid 50s, the premium's a little higher. So if they don't qualify for the subsidies, we find people are often caught off guard by that cost. But you mentioned the subsidies, and so walk us through. This is a slide that sort of explains how it works, but tell us a little bit about how those tax credits work.
Yeah, so basically, when you go into the marketplace, if I help you with that as a broker, we're going to do some very rough income calculations. It's part of the application process. You're going to talk about the money that you made in the year. You're going to talk about maybe some retirement distributions, things like that. So you get a pretty good snapshot of what your yearly income is going to be. Now, thinking back to that previous slide, let's say the retail cost of a plan is $1,000, or $1,300 for you and your spouse. If your income is low enough, as you can see on these charts, really anything over 100% of the federal poverty line and beyond, even in excess of 400%, you're now still eligible for subsidies. So basically, the higher your income, the lower your subsidy may be. Now, if it gets too high, you just won't be eligible for subsidies. But you're actually talking about more money than you might think. It's quite high from what I've seen.
Yeah,
Many people.
We see that too, and I know the rules changed last year, maybe it was the year before, but in simplified terms, sometimes I explain it as, even if your income is greater than 400% of what's called the federal poverty line, they now say they're going to look at your modified adjusted gross income, and your expected premium contribution would be 8.5%, and that you could be eligible for a credit for any cost that exceeded that amount. Does that sound about right?
Yes, that's completely correct. And then the other thing that's nice to know too, I run across this a lot helping people right here in Scottsdale, is even if your income is in the six-figure range, if you have children or other dependents, that can also help to boost that subsidy. So it's quite, helpful to not just say, oh, I don't think I'm eligible, I don't even want to mess with this, because it's sometimes a very surprising amount that you can save on this insurance, depending on what your family size is.
I I will absolutely second that. We have seen, I think the maximum amount we saw was someone that saved, over 30,000 a year by
Mhm.
becoming eligible for these credits. And it was a household that had a $2 million net worth, but it was by structuring what is actually counted as income. So I know the technical definition at this phase of modified adjusted gross income is adjusted gross income plus the non-taxable portion of Social Security. So if either half, if you're married or either of you is getting Social Security, you have to add back the non-taxable portion plus tax-exempt interest plus any untaxed foreign income. So there's all kinds of different definitions in the tax code of MAGI. But down here at the bottom of this slide, we have a note from, a snapshot from the cover page of someone's 2022 tax return. And what they did is they put into the system their estimated modified adjusted gross income, and we're able to, to let them know what that will be. And it told them that their advance payment, so advance credit was $16,524, so it reduced their premium by that amount. And then when they file their tax return, there's sort of a leveling up, just like how we get a refund every year of our taxes. And so their actual tax credit was $16,311. And then the excess credit that they were given was due on their tax return. So this was, $16,000 to me is substantial. You've seen cases like this also?
Oh, yes, no, absolutely. And usually when I'm helping somebody with this, I say, let's maybe overestimate the income so you don't have a tax liability at the end of the year. And then worst case scenario, every plan that you choose through this platform is basically going to have a retail cost that it shows you. And I say, worst case, you would have to pay the difference of that. So it's not the sky's the limit. You're going to be paying hundreds of thousands of dollars back or anything like that. It's a very known quantity.
Yeah, that's good to know. Where I really see people struggle is trying to estimate their income, because in retirement, somebody, for example, could withdraw money from savings and they're going to be using that to cover some of their expenses. Well, that withdrawal is an income on a tax return. And so helping people understand like what is actual income when you're retired in terms of this definition, sometimes people have a challenge with that.
Yes, absolutely. And that's why, we're happy to have people like you helping to sort of clarify that picture, because I'm not a CPA by any means, but I know how to plug the numbers in there. So.
Yeah, and we always like to qualify. We're not CPAs either, but when it comes to tax planning for retirement, we definitely do a lot of detailed work in that area. Speaking of that, one of the last things I wanted to touch on in this pre-age 65 phase were health savings accounts. We deal with these a lot with clients. Mike, there are, of course, plans that pair up with HSAs. You want to tell us a little bit about that?
Sure. So, one of the most helpful, I think, underutilized retirement planning vehicles that you can use is actually a health savings account. So you get to contribute money pre-tax, you can grow it pre-tax, and then you can withdraw it tax-free, provided it's used for eligible medical expenses in your retirement years. That can be super helpful for paying various Medicare premiums and things like that. But really, you just have to pair it with an eligible high deductible health plan. They're very well known. They'll expressly say this is an HSA eligible plan. And then you get to contribute some money, and then you can use that for future expenses. I kind of tell everybody, if you're using your HSA to pay your, co-pays and thing every year and kind of using it like a year-to-year slush fund, that's maybe not the most effective way to do it. But if you let it grow over time, you can have quite an ocean of money to help you pay for healthcare expenses down the road.
Yeah, we see that all the time. People fund their HSAs and then immediately, most of them have a debit card now, so they're using them for their co-pays and try to get people to realize that power of tax-free growth. Let's fund that thing. The maximum funding limits are in our last bullet point down here. So let's fund it, and then let it grow. And then we will actually even develop a plan now for when is the best time to use those funds in your HSA. So they're not a very efficient vehicle to pass along to heirs. And so we've started to either have a plan to use them to pay the Part B premiums in retirement. Sometimes we'll say, if we can use them up right around the time that, your required minimum distributions start, but we might want to use them up before any long-term care expenses start, because when long-term care kicks in, you may end up with a lot more itemized deductions on your tax return. And so we'll develop some strategies. Speaking of long-term care, Nicole, I wanted to ask you, I know qualified long-term care premiums can be paid out of the HSA. I just want to verify that is correct?
That is correct. A long-term care, a tax-qualified long-term care insurance premium is one of the approved expenditures out of an HSA. So
now tell us, what does that mean, tax qualified?
Well, the Health Insurance Portability and Accountability Act of 1966, better known as HIPAA, defined tax-qualified long-term care insurance requirements. And tax-qualified means that benefits paid are not taxable and premiums paid may be tax deductible depending on how policyholders file their taxes. Tax qualified policies have only two triggers to benefit eligibility. One of those is that you need assistance with two activities of daily living, and those activities are defined as bathing, dressing, eating, toileting, continence, and transferring. The other trigger is supervision due to cognitive impairment. And with either one of those triggers, the need must be for a minimum of 90 days. There's some other things that are required with tax qualified plans. For example, they must be guaranteed renewable, which means that an insurance carrier cannot cancel a policyholder for any reason other than non-payment of premium. And then there's some other consumer protection requirements that go along with tax qualified plans.
Now, what I'm hearing is if I want to know if my plan is tax qualified, I should call you.
Well, yes, do that. But to my knowledge, there's only one carrier that still offers non-qualified, non-tax qualified plans. The difference is there is a third trigger to benefit eligibility, and that is simply a medical professional can say care is needed. Now, the downside with this is, while benefits are paid tax-free, there has never been any tax law on whether or not premiums can be deductible. So that's the basic difference.
Okay. So most of the plans, it sounds like, being issued today are tax qualified.
Correct.
Okay. Now, I know we talked about this before. We're talking about being able to pay for those out of an HSA, but what about business owners?
Well, with HSAs, they both employers and employees can realize a benefit.
Oh, and I meant really about long-term care. Like if I don't have an HSA, but I'm a business owner, is there a deduction that I can get for buying long-term care, on a Schedule C or through my business?
Yes, and it's very complex. The only one that isn't complex is if you are a C Corp, then 100% of premium for owners, employees, spouses, and so forth are 100% deductible. But when you get into pass-through corporate entities, it's pretty complex. So if you're an
Okay.
S corp or a partnership or an LLC, it depends how you file taxes under an LLC. So it's complex.
It's complex. Yeah, I think the thing we see is we tell people, let your tax preparer or CPA know that you have this long-term care insurance policy
Yes.
and that you're paying the premiums, and that you'd like them to look into and see if there are some deductions available. So I think in some cases there are, and I know you're not the expert on tax, neither am I, but we know that we see people miss this, and so we just say, bring it up. Let your tax preparer know. Say, hey, could you look into this? I think there might be something available for me.
Yeah.
And I know on the HSAs, we've got the, the family limits up here. That really applies if it's you and an additional person on a plan. But there's individual limits also. So the single limit for 2023 is $3,850. And if you are age 55 or older, you can contribute an extra $1,000 as a catch up to your HSAs. Moving on past our pre-age 65 phase, now we start to look at what happens when we reach 65 and become Medicare eligible. And there are many different parts to Medicare. We want to talk about it's complicated. You're going to hear us say this a lot. Derek, I know this is an area you're very familiar with. Walk us through what's on this slide here and all the different parts of Medicare.
Yeah, absolutely. So many times when I meet with somebody, it's very complicated. They're very confused of what Medicare is and what the different parts are. And I try to just kind of, lay it out very simply. When you think about Part A is going to be hospital insurance. Really what that means is room and board. So when you go to the hospital, it's basically securing your room. It's not the treatment that you're going to receive there. It's just saying, hey, I'm going to be going to the hospital. I need the room. I'm securing the room. There is a deductible that goes along with it, and you can see at the bottom of the screen there, it's a $1,600 deductible. That deductible is a period deductible, so you can hit that multiple times in a year. Now, the good part is once we get to that back section, there's ways to get around that deductible. But Part A basically secures your room. You can get some other things like some blood treatment there under Part A, but really the bulk of everything that you get is going to fall under Part B. Now, with Part A, as long as you work 10 years or 40 quarters, you do get that premium free, so you don't have to pay an additional premium for that. Really, what most people are concerned about and see on TV about penalties and things like that falls under Part B. So Part B is going to be all of your medical treatment. That's going to be your inpatient, outpatient hospital visits, surgeries, anything along those lines. So you go to your primary care physician, that's going to be Part B. Now, the base premium for Part B is going to be $164.90. Now, based off your income, that can change, which is called an IRMAA adjustment. I know you educate all your clients with that. So depending on what you file, single or joint, that's going to affect how much you have to pay to the government. And this is to the government. Okay, so now when you have Part A and Part B together, that's when you get that red, white, and blue card. That's what we call original or traditional Medicare. So that does have a deductible. Now, when you pay your deductible, and it seems to be very low, which is $226, once you pay that, that basically triggers 80-20 coinsurance. 80% the government's going to pay, 20% you have to pay. The downside to that system by itself is the sky's the limit. So if you go in for $1 million claim, 80% the government's going to pay, 20% you have to pay. So you can see why it's very important to, when we get to that back section, that you want to have some type of stopgap. Now, the other side to this is this Part D, and it's an easy way to remember it because, D is for drug. So anytime you want to go to the pharmacy, you need to have a Part D prescription drug plan. Now, this is very easy to figure out for somebody because it's really just dependent on what someone takes. So, I'm in the state of Arizona. So for me, all I have to do is just say, hey, what medications do you take? I plug it into a system. I know exactly how many plans are in the state of Arizona, and it basically can rank based off your medications, what's going to be the cheapest option all the way to the most expensive. So there's really no guessing game with this. So you don't have to worry, hey, am I going to do, hit this, the gap or what they call the donut hole. It's just really based off what you take. So now that you have kind of Part A, Part B, and then Part D, now it's like, what do you want to do for your secondary coverage? So if you want to retain the benefits of, Medicare, then you're going to want to have to pair it with a supplement. And so the way it works is once you meet that deductible under Part B, which is $226, the supplement company will now pick up any overages that you have. So they will pick up that 20% share of cost. Now, the downside to that system is you do have to pay an additional premium for that. So one of the things we look at is rate history. We look at the company itself, and that's how we kind of determine, what would be a good fit for someone. The other option is, and we're going to cover that a little bit more in some of the slides, is going to be Part C, and that's what most people see on TV right now. That's going to be your insurance companies, just throw out a few names, but your United, your Humana's, your Aetna, all those big name companies. So the way it works is you assign your Medicare benefits to this insurance company, and they now manage your care. So it's very similar to what you have with group health insurance. It's going to be an HMO or a PPO type plan with co-insurances, co-payments, things like that. So you'd be very used to doing that type of system. But again, you just have to be familiar with how it works versus original Medicare. It's two completely different systems.
Yeah, and I want to clarify that because I know the way we lay it out here, I have Part A, B, D, and C, like they all go together. But reality, it's original Medicare plus a supplement or original Medicare plus Part C. Is that a good way to describe it?
Correct. So no matter which avenue you go, you have to pay the government the Part B premium. So you can never outrun that. So sometimes I say, hey, if I want to get this Part C, let me just take that. I don't want the other part. It's like, well, you still have to pay for the Part B to the government. And if you think about it like this, you pay Part B to the government, they basically ship that over to the insurance company to now manage your healthcare under Part C. So that's an easy way to think about it. Or like we kind of mentioned the first way, you keep the Part A and Part B and then pair it with a supplement. So now you're just basically paying the government for one part and then you're paying for your supplement on the other.
Yep. I love the way you described it and how you explained the deductible and then how the 80-20 rule kicks in. There's several things you said that we're gonna come back to. One of them is the IRMA premiums, so we'll come back to that. Another is, what can happen if you don't have supplement insurance. But before we get to that, I want to talk about the actual transition. So I know we get this question all the time, like, I'm 65, I'm still working, or my spouse is still working. What do we do? And so walk through that decision for us.
Yeah, so one of the things that we do when we sit down with clients is, we do basically an analysis. We say, hey, are you currently working? And then typically they are working, and we say, hey, how many employees did you have, at that company? Because that's a big question. Under Medicare, they basically, they look at it and say, hey, if you have 20 employees or more, that's considered creditable coverage. So if that's the case, and someone does have that, we can say, yeah, you actually do not have to take Medicare. And at that point we say, okay, now it's just a, stay or go analysis based off your premiums that you pay with your group health insurance, your co-payments, your max out-of-pockets, things like that. Does it make sense for you to stay there, or does it make sense for you to go to Medicare? Now, if you're, a business owner and you have 5 employees, and this happens sometimes, where someone will say, hey, I don't need Medicare, I'm employed, and we ask that question, how many employees do you have at the company? And they say, we have 5. At that point in time, we would say, okay, based off those numbers, it's not going to be creditable coverage. You will need to come on to Medicare, because if you don't, that's where you may incur penalties down the road, when you finally do get on the Medicare.
Yep. And then I know, there's a lot of times we get asked the question, people have heard about penalties, they were still working, assume they were on a plan that had creditable coverage, and now they're 67. And so, how do those special enrollment periods work? Can they just transition right to Medicare, even though they're way past 65 at that point?
Yeah, absolutely. And when we sit down with someone, we let them know, hey, if you do decide to stay on your group health insurance, you can come transition to Medicare at any point in time, because you do have creditable coverage. It's a very simple process. At that point, we give them some paperwork that they have to fill out. The HR staff will have to fill out, and it gives you an enrollment period just like you were turning 65. You get no health questions asked. Choose the plan that you want. We lay everything out for our clients and say, we go down, hey, do you want to go with a supplement? Do you want to go with an Advantage plan? We look at all the different companies, but really the process is just exactly the same as you were turning 65. And we let everyone know, you don't have to take Medicare. If you are in creditable coverage, you can take Part A. It's independent for each person. But really, when you are getting that special enrollment period, you don't have really anything to worry about. It's just like you're turning 65. If you're 80 years old and you're planning to retire off your group health insurance, it's going to be the same process.
Good. That's good to hear. And then let me ask you, you use the situation, a small business owner, 5 employees, thinking, well, I don't need Medicare. And I think I had a client that might have fit that description, and you guys might have been able to help them. But in those cases, suppose that person just was going about their business and didn't even realize, and what happens? Are they then subject to penalties when they sign up later?
Yeah, so if they decide, that perfect example, they come on at 67 and they just had not credible coverage, the government's going to basically say for every year that you did not enroll in Medicare, there's going to be a 10% for every year penalty, and that's a lifetime penalty. So it's something that you can never outrun. So it's not something you can just pay up front and be done with it. It's going to be there forever. And then also, we'll get into it too, but with the drug plans, there's a penalty on that as well. So it's not just the penalty on Part B, it's going to be the penalty on the drug plan as well.
Wow. Yikes. So if you are supposed to enroll in Medicare, you better do it on time.
Well, and that's why we always say, if you're unsure and you're getting close to it, that's why they give you a 3-month period before you're supposed to enroll. You should always talk with a professional. We kind of joke around and say, sometimes your neighbor doesn't know everything. So if you do have any questions, just contact a broker, contact someone who may know, just so you don't put yourself in a bad situation long term.
Yep. Well, and I'm going to have a few more questions related to some of this, but one more right now. Retiree medical plans. So I know as a financial planner, I've been practicing for over 25 years, and it used to be standard recommendation. Like if a company's employer offered any kind of medical into retirement, it was like, of course, you're going to take that. But I don't know that that's always the case anymore. What do you see?
Yeah, it's different for every single situation. Sometimes those retiree plans are phenomenal. And it's really just it's when we sit down with them, it's just an analysis. What is the retiree plan and how is it structured? Some of them are fantastic and they have great benefits. Sometimes what they are is they're just an advantage plan, which you can get on the market for almost zero cost, and then you have to pay out of your pension for them. Sometimes a very high amount of $300-400 a month, and it's exactly the same as what you can get on the open market. So at that point in time, when you do have the option of a retiree medical plan, I would say just again, contact the broker, see if it's a good option. Weigh your options, and if it is a good fit, honestly, if someone contacted me and it was, I would say this is going to be the best bet for you. You should stick with your retiree plan. Or if it wasn't, I would say, hey, maybe you want to consider something else and looking into something else because it may be a better fit for you.
Yep. Always the case where it makes sense to explore options.
Absolutely.
My last question on this, and we're going to move to a different slide because we talk about the case where you are 65. Now, again, I know as a financial planner, our standard advice before health savings accounts came around was, you enroll in Medicare, and we still see people who do, even though they don't have to. And so we kind of see that almost as a standard practice, but it can have an impact, I know, on your ability to contribute to a health savings account. So, walk us through that. What happens there?
All right. So yeah, with an HSA account, if you're going to be transitioning to Medicare, you can contribute to that all the way up until you're 65. That's one of the questions we do ask somebody when they are getting ready to enroll in Medicare. Do you, with your group health plan, do you contribute to an HSA? So if you do plan to stay on your group plan and you are contributing to an HSA, there are some rules that kind of go into play. You can continue to contribute to the HSA account, but you want to just be careful because if you are going to enroll in the Medicare, you want to shut that off 6 months in advance to when you are getting into Medicare because there are some tax implications and things like that. So again, it's just a simple question. Do you contribute to an HSA? If so, yes, and you do plan to stay in your group coverage that is creditable, we'd let them know to say, hey, just before you're going to enroll into Medicare, turn that off, stop contributing 6 months in advance. If someone just says no, then there's really no worries, and then you can take, you know, Part A if you want, or not take Part A. It just really depends on your situation.
So let me ask along those lines, because we had this conversation when we were preparing for this, and I had the slide up here, and I had said, you know, the general rule of thumb is we tell people to stop the HSA contribution 6 months before, but you said there was perhaps sometimes it needs to be as much as 9 months before.
Yeah, so they're always going to do, they're going to always retroactively start your Part A. So when you're, you know, contributing to that, you just want to make sure you have plenty of time before you shut it off. So again, 6 months is kind of the rule of thumb, but you know, 9 months to be safe. It's kind of what we tell everybody.
Okay. Now, there's still so much here when we get to Medicare. So we talked a bit about original Medicare plus a supplement, or, you know, adding Part C instead of the supplement. And we often refer to that as either a Medigap or an Advantage plan. And it's one of the biggest questions we hear from our clients at this stage is, which one do I pick? So let's walk through that for us. How do you help clients decide this?
There's really no right or wrong answer. So once we start sitting down with somebody, we start asking just a series of questions. You know, again, Arizona in our backyard, we have Mayo. So one of the questions we first ask is, do you have plans to go to Mayo, or do you see a doctor at Mayo? Out here, you know, they do not accept Advantage plans. So that's a clear-cut one for us. If they want to go there as a primary care physician, that eliminates one of the options. But really, we ask, you know, some questions like, do you travel quite a bit? You know, obviously Medicare is in every state. So if you do travel quite a bit and you're going to be in multiple states, you know, throughout the year, Medigap plan can be very appealing because you don't have to worry about in or out of network charges. You just follow the rules of $226 you know, dollar deductible. And after that, you can go see any facility, any doctor that accepts original Medicare. It's a fee-for-service plan. So if the doctor says you need a knee replacement or you need to have a new kidney, you get it because the doctor is saying it, and that's what you're going to get. So there's less moving parts on the Medigap side or a supplement versus an Advantage plan where it's going to be a network-based plan. So, you know, if someone wants to have an Advantage plan, again, you're in an HMO or PPO. So an HMO is going to have, typically you're going to have to see your primary care physician before you can go see a specialist. They're starting to kind of move away with that a little bit now. They also are starting to have national networks with the HMO. But the PPO gives you the ultimate flexibility of choosing your own doctors within that network. But again, it is a network. So when we start to go down that avenue of Advantage plans, we want to make sure that there is a large network for our clients, that they have plenty of doctors to choose from. The Advantage plans, they do change yearly. So every year we do review the plans for our clients as well as the drugs on those, just to make sure it's still a good fit, because I kind of, you know, say that Advantage plans are like tires on a car. They start to wear out as time goes on. So you always want to put a new set of tires on, because they always come out with new Advantage plans. You want to have the best and you know, the best plan that's going to be fit your needs with the Advantage. Also,
yeah, I like that. Go ahead.
Yeah, also too, on the very last part, with the Advantage plan, so they do offer some additional benefits like the over-the-counter benefits. So if you want to go get vitamins somewhere, they do include that. They're going to include some dental, some vision, some hearing benefits. Again, it's not a ton, but it also does help out. So if you are looking to not spend on those, that may be an attractive plan for you.
Oh, talk about some of the risks. I know what I've heard is if I sign up for an Advantage plan and then later, like I have a big health event and I need to go back to a supplement plan, I'd have to go through underwriting. Like, is this true? Or there's some risks there?
Yeah, so there's some maneuvering that goes along with these. You know, typically if someone's really on the fence, you know, I'd also say, hey, maybe you start with a Medigap or a supplement, because after 6 months of being on the plan, you have to answer medical questions to be on a Medigap plan. If you were to, you know, switch a plan, or someone wanted to go on to that. So after 6 months, you'd have to answer questions. You start there and you say, you know what, I'm paying this additional premium for this plan. I don't really utilize it. I want to try the Advantage plan. Well, you have the ability to switch over to an Advantage plan, and they will give you what's called a 1-year trial, right? So they will say, hey, you can try this Advantage plan out. It's really 11 months to be safe, but a 1-year trial, you can try it out. And again, if you do not like that Advantage plan, you have the ability to make another move right back to that same supplement that you had before. So you can make 2 moves with that. If you start with an Advantage plan, and you go longer than 6 months on that plan and you want to go try a supplement. Now, if you want to switch and you do have some type of chronic condition, you're going to have to answer medical questions to get onto a Medigap plan. And at that point, you may be denied coverage, and then you're kind of stuck on the Advantage plan until you're able to pass medical underwriting.
Wow, that is a really important distinction, I think. You know, it sounds like if you want to keep all your options open, you would start with a supplement plan, and then it allows you that free trial if you want to go the other way.
Yeah, and again, there's really no right or wrong answer with the Advantage. I know I have a lot of clients who take Advantage plans and they're thoroughly happy. I've seen them work where I've seen hundreds of thousands of dollar claims where the client's only paying, a few $100s on it. So I've seen that work too. So again, there's really no right or wrong answer. It's just what's going to fit your needs the best.
Yep. Yeah, and I know I've said it can vary so much by location. So, there can be one area where the Advantage plan's great, and then a different part of the country, or even a different part in the same state where it's like, oh, that's not so great.
Absolutely. We see that a lot, being licensed in multiple states. You can see Advantage plans where, in certain states, they're extremely strong, where there's low max out of pockets, and all the benefits are very good. And then the premiums for the, supplements can be very high. So it makes the Advantage even more attractive versus other states where maybe, the Advantage plans are more expensive in the long run.
Yep. Well, speaking of expensive, I wanted to talk a little bit about this. It comes out of a research paper done by Vanguard and Mercer. And on the left-hand side, they were illustrating if you had original Medicare, and they quantified people according to different healthcare risks. Some of them were high blood pressure, cancer, diabetes. So there was a series of about 12 different categories that if you had any of those, it might put you in this medium or high risk. And they said, if you have original Medicare, the blue is the premium you would expect to pay, and then the light blue are your estimated out-of-pocket costs. And you can see in this, I don't really consider this worst case because I'm going to ask you in a minute, Derek, about a story you told me about, but that here you could have a pretty hefty out-of-pocket cost. Now, if you're adding a supplement plan, here they use supplement plan G, it was capping these out-of-pocket costs. So I like to use this just to illustrate, the risk of going without a supplement or an Advantage plan. Derek, we were talking about this. I think you had a story around that 80-20 of what someone ended up having to pay. Can you share that with us?
Absolutely. So yeah, with original Medicare, and again, when we sit down with someone, you have to have Medicare either way you go, Advantage plan or if you want a supplement. The one thing we don't recommend is taking original Medicare by itself. I've had someone call me up, again, that story that we talked about. I got a phone call from a wife, and she said basically, hey, my husband went to the hospital. He was there for an extended period of time. We received a bill for $70,000. And I said, well, what's your secondary coverage? They said, we didn't have one. I said, well, unfortunately, that's your share. That's the 20% that you have to pay because you don't have any secondary coverage. So that's the downside to having no what we call safety net on the back end. And that's where you can see on that, the worst case 95th percentile. I mean, if you get a serious case, you go to the hospital, car accident, any of those things, you're willing to pay 20% of whatever that bill is. So that's why it's important to have a secondary coverage like the supplement. The worst case scenario that you're going to have to pay is with strictly healthcare is that dark blue section, because your fixed costs. Once you pay your premium to the government, once you pay your premium to the supplement plan, you pay your deductible, and as long as you're getting Medicare approved charges and nothing outside of that, then your fixed cost for every year. Now the premium will go up year to year to year with medical inflation. That's just the way it goes with a supplement. But what you're going to be paying each year. So that's the plus side to having original Medicare and a supplement. Now the light blue there, that's going to be more of your out-of-pocket costs for like dental, things like that. So those can actually fluctuate. We were talking last time, and some dentists now are not accepting insurance, so the costs are going a little bit more with dentists and things like that. But those are going to be more of your outside of healthcare costs.
Wow. Excellent. Yeah, I completely agree. Like I like how you described it as knowing your maximum out of pocket. for us doing retirement income planning, that's so key is,
Yeah.
we want to limit those surprises and know that we can manage cash flow for known expenses, and having those supplemental policies in place helps so much.
And you can do the same with an Advantage plan because they do have the max out of pockets on them. So you can say, hey,
Yep.
worst case scenario is going to be this is the max out of pocket on the plan. So you can just kind of budget that into. But with the supplements, it tends to be lower when you are younger, and then it kind of the two plans switch as time goes on.
Yep. And I wanted to add in here, speaking of healthcare costs, this is another slide from that same research paper where they looked at the percentage of household expenses that healthcare takes up. And you can see as you move from the age 55 to 64, 65 to 74, and then age 75 and older, those percentages increase. But on the right-hand side, it shows that spending in other categories tends to decrease. And we see sometimes the media headlines and they talk about this big number, it's going to cost $300,000 for healthcare over your retirement. And sometimes I try to break that down and say, if you lived 30 years and that was $10,000 a year, that doesn't sound quite so scary. But I also like to remind people that, as they enter the slow go years, spending in these other categories does slow down. And so they're not shopping as much, eating out as much, traveling as much, replacing all the furniture in the house or remodeling. Just some of those things slow down. And so although healthcare does tend to take up a increasing percentage of your budget, it's not always stacked on top of what you're already spending. Now, the last thing in this age 65 transition to Medicare I wanted to touch on, and you mentioned it earlier, Derek, were these IRMAA premiums. So IRMAA stands for the Income Related Monthly Adjustment Amount. We use this schedule to show people, what they might pay depending on their modified adjusted gross income. How often do you encounter people that are having to pay these extra premiums?
Every day. So I actually, me and Mike went to a seminar out in, it's Casa Grande here in Arizona, so it's about an hour drive. I had a family, one of my mom's friends, called me up and said, hey, I received this letter, what do I do? Well, unfortunately for her, it's a good and a bad problem. She made a ton of money. She was in that almost the second to last bracket. She's a single person, so you can see the how much she made there. But I just told her, I said, hey, look, here's what we can do. We can always look at what you're currently making because they do a 2-year look back. So if you're in this year, they're looking at 2021, what you made. So that was when she had a very large amount of money. And so what we said is, hey, let's at least fill out an appeal form and say that you don't make nearly as much as what you did 2 years ago. And the worst case that they can do, at Social Security is say no, but they reviewed it. They set her up with a phone appointment. They actually approved it for her. So she was able to go back to the base premium, even though she had a very large distribution that year. And so it did pass. Now, I've also seen it go the other way where someone filled it out, and unfortunately, Social Security said, nope, you pull that distribution. That's going to be a 1-year problem for you. The great news is it adjusts every year. So they're always doing a 2-year look back. So if you did have a one-time distribution, you just know that you have to get through that 1 year, and then after that, it's going to go back down. It's always going to adjust for you, so you don't have to always, be worried. Hey, am I going to be paying $561 for the rest of my life? No. As long as your income comes down, now if you are in that bracket, single, you did very well for yourself for your whole life, so I wouldn't really worry about your premium. But with that being said, if your income does come down, it will adjust.
Yep. Yeah, and I was asking how often you see it because I think I've seen some stats that say, impacts 5% of the population. Now, I know, as a financial advisor, we are lucky to work with people that have saved more and probably are, in the top income brackets, but we see it all the time too. And so, people are impacted by this all the time. Sometimes there's some planning that we can do to keep them from crossing over into a next tier. But sometimes, like you said, we're doing Roth conversions or something that we have to say yes, and this will make you go into a higher tier and pay these higher premiums, but it's still worth it. And so we will quantify that so people can see that despite that, it's still worth it. And then as people retire, they will often get their initial determination letter, and then we're letting them know, retiring is one of the reasons you can file an appeal. You don't have the same income you had while you're working. So don't just accept the $528 a month premium. That's not your income any longer. And so substantial savings can be had by paying careful attention to those letters that come in.
Absolutely, and that's why you're a professional. We were able to help out, one of your clients, and he already had a great idea about IRMA adjustment. So you did, a good job of prepping them for that.
Good, that's good to know. Well, kind of wrapping up this section, I wanted to lay out how much healthcare costs can vary as you go through this transition. So on the screen here is a sample timeline of just healthcare expenses. So it's an estimate for a fictitious couple named Sam and Sally, and Sam is 62 at year end and Sally is 63. And so what we see in the first line for each of them is their estimated premiums off a healthcare.gov plan, assuming they do not qualify for any of the healthcare tax credits. And then the next line, we see when Sam turns 65, he's going to start a Medicare supplement policy. His birthday's toward the end of the year. And so you'll see just a partial year premium there. And then in 2027, his full year premium for a supplement policy. And then we have estimated out-of-pocket costs, and then you'll see Part B costs. Now, if you go all the way to the bottom, and both of these are prorated based on their dates of birth, their month of birth, because when you transition to Medicare, it's going to be during a specific month. But what I find so interesting is they start off at 30 and go up to 31,500. We're using 5% increase in our estimates here. And then it goes down. And so by the time both are on Medicare, their premiums are not quite, but almost $10,000 less than not just premiums, but their total all-in estimated costs. And people are often surprised to see that. And so we just like to remind them that, your most expensive years, if you don't qualify for any of the tax credits, are often going to be if you have retired pre-65. And so that doesn't mean you can't do it. A lot of times we can budget for it. We just make it part of your distribution plan, but it often will come down later. And Mike, Derek, anything either of you would add to this? Is this what you see?
Yes, it's absolutely true. And then, a lot of people are surprised with, Medicare being more affordable. They think it's going to be terrible coverage. And I tell everybody, you funded this for over 40 years. It's time to take advantage. So just remember all those payroll deductions from the time you were 15 to 65 that help do it. So, but yeah, no, it does get drastically less expensive on Medicare unless you qualified for extreme tax subsidies up front on the marketplace.
Yep. So there's a little bit of good news out there. Moving into the last section, talking about our later years. Nicole, I know we talk a lot about this, and I still hear people, with this misconception that, well, Medicare will cover my needs. So tell us a little bit about the difference between medical care and long-term care, and why doesn't Medicare cover all your long-term care needs?
Well, actually, part of the confusion is years ago, Medicare did cover long-term care. And so we still have people who may have had elderly parents and Medicare covered their care. But Medicare, healthcare, Medicare, and long-term care are very different in design. As Derek and Mike have explained, Medicare is curative or rehabilitative or preventive in design. And long-term care is custodial care. So long-term care provides the assistance when we can no longer live independently. That can be the result of a chronic illness like diabetes, a disability like a stroke, cognitive impairment like Alzheimer's, or just plain growing old, becoming frail, and needing some assistance. And it provides assistance with activities of daily living, so bathing, dressing, eating, toileting, and so forth, or supervision due to cognitive impairment. The number one cause for long-term care claims today is cognitive impairment. And claims history varies from carrier to carrier, but insurance companies have reported that between 35 and 66% of their claims are tied to dementia. And that over 50 cents of every claims dollar is tied to dementia. You can receive long-term care in a whole range of venues, in your home, adult daycare, an assisted living community, skilled nursing, memory care, even hospice. And then when you look at the triggers for eligibility for insurance benefits, we talked about this before with the qualified, tax qualified plans. So there are two triggers. Either you need assistance with two activities of daily living or supervision due to cognitive impairment, and that need must be for a minimum of 90 days.
That's usually the insurance company's definition to trigger benefits?
No, that's actually HIPAA's
Okay.
definition for tax qualified plans.
Got it. Okay. Now, I know you provided me the slide, the pricing data on here around the monthly cost. And so we have, monthly costs for maybe a home health aide at $5,500, all the way down to a private room at around $9,700. Now, I will often tell clients, if you're single, for example, you needed a private room, yes, the cost is $9,700, but let's say the person has Social Security and a pension coming in, already at $5,000, they do have some income coming in to offset that. And I know when I've worked with you, sometimes we'll try to quantify that and say, well, you might not need a policy that covers that full dollar amount, but you might need a policy that covers this differential.
Right.
Would that still be, an accurate way to look at it?
Yes. Years ago, there wasn't much customization of these policies. People bought lifetime coverage, 100% coverage for lifetime, usually with a 5% inflation rider. And it was in about this product has been in the market since 1974. It was about 2005 when there was finally statistically relevant claims history to understand if policies were being designed and priced and underwritten correctly. At that time, we changed what we were doing, and we now know that between 4 and 5 years of coverage serves most clients very well. And when we look at coverage, we certainly want to be sure that a premium is in concert with the rest of the financial plan, because it's got to be affordable. But what we look at is offsetting between 50 and 60% of a private room in a nursing home. That will typically cover home care and assisted living. And today, most care is at home, and very little is in skilled nursing facilities today, only about 13%. So what we want to cover is the home care cost and assisted living. And when you look at the costs here for home care and homemaker services, we're looking at 44 hours a week. Now, why? Because 44 hours will fund 5 8.5-hour shifts. So if you've got a parent living with you while you're at the office, the insurance coverage will cover the shifts. Family takes over at night and on the weekend. So that's what the 44 hours equates to. It also equates to 4 or 5 hours a day. And we think if you need more than about 8 hours of care a day, you're going to be better off from a cost standpoint or from a care standpoint to be in assisted living where you have 24/7 non-medical care.
Interesting, unless, you are willing to pay to get premium care at home. Like I'm hearing you say not only, from a cost savings, but also the quality of care might be better in assisted living. Can you?
Could be. Mm-hmm.
It could be. Okay, yeah, it would depend on I'm sure the type of person that you have coming into your home. There's some that are very attentive and maybe some who aren't. Well, thinking through this, I know in the past I've used this slide on my webinars and talked about different ways to fund this potential expense. And my first slide used to say self-insured. And Nicole, as you and I were talking, I found out that is a pet peeve of yours that us financial planners say. We call it, oh, you can self-insure. So tell me more about why that's a pet peeve and why you would like us financial planners to stop using that term.
Well, thank you for bringing that up. Self-insuring is really a misnomer. The very short definition of insurance is that you are transferring risk. So if you're assuming the risk, you're not transferring it anywhere, you're really self-funding. And I think if we use the terminology self-funding and then explain what that might mean, that our clients understand the importance of self-funding. So if you're self-funding, you're paying for care out of income savings, liquidating assets, maybe doing a reverse mortgage, but you're using your assets to pay for care. So
I love that distinction. I mean, as soon as you said it, the light bulb went on for me. I'm like, yeah, self-funding is the right term. So I'm in alignment with you. And I just, I'm laughing at myself. And I know, I think it's a great distinction to make. Tell us a little bit about, these different ways to fund. So who might qualify for Medicaid and what does that look like?
Well, Medicaid, not Medicare. Medicaid is the primary funder of long-term care in the country. And Medicaid is means tested, and it really is a program that is designed for custodial care for the indigent. And to qualify, you may have to spend down assets to qualify financially. But it is the primary funder of long-term care in the country. And
when you say spend down, to almost nothing, I know it varies by state, but is there a rough guideline?
Well, if you are a single individual, you're allowed to keep $2,000 of assets.
To almost nothing.
Almost nothing. It's designed as a program for the indigent. And if you are a married couple, the rules are different. And the rules are different in each state, basically. There are different rules. For example, in some states, Medicaid will only cover care provided in a nursing home. In other states, Medicaid will cover any care venue. So it's different. And then if you're married, then we don't want to impoverish the healthy spouse. So there are rules, different rules in terms of how much of asset the healthy spouse can retain. But I think, of course, we're biased, but self-funding and qualifying for Medicaid are very expensive ways to fund long-term care expense.
So yeah, talk to us about the options of transferring that risk to an insurance carrier.
Well, when I started my business in 2001, there were about 140 carriers offering long-term care insurance products in the country. Today, there are about 25. And there's very little new product coming into the market. So basically, there is a traditional product, excuse me, a standalone product. I explain this to my clients in terms of auto insurance. You figure out how much coverage you need, what your deductible will be, you pay your premiums, you hope you're never in a crash, but the money's gone. You don't expect to get any premium dollars back. Now, one of the things that is attractive about these traditional products is that the insurance carrier takes on all of the risk. The policyholder is not sharing in the risk, as they do with hybrid products. With a hybrid, and they have become very popular, but a hybrid product rides on a life insurance chassis or an annuity chassis with long-term care riders. So these are more expensive products. They most of them require a fairly substantial premium to create the death benefit on a life insurance or cash value on an annuity product. And so here, because there is cash value, the policyholder actually shares in the risk with the insurance company. These products have two resources to pay for care. One is the life insurance. The death benefit becomes the first resource to pay for care before an extension rider. The death benefit is the first resource for care. That's the client's money. If the death benefit is exhausted, then the money that the carrier has at risk becomes the second resource for care. And so the policyholder is actually sharing in the risk with the insurance company. Now, what people like about these hybrids is if you never need care, you get the money back. With life insurance, you've leveraged your premium, you're getting more money back. With an annuity, you get cash value, usually with some interest. So those are the two product designs that are in the market. There's either the traditional product or the hybrid.
And I want to qualify something. When you mentioned the traditional product, I think you said, all of the risk is borne by the insurance carrier. And I know what you mean, but I also want to quantify most policies have a limited pool of benefits. So would it be true then if you had someone had an extended stay, they could still use up all of the benefits from the insurance carrier and still have some risk that came back to them?
Oh, if you had with all of these products, all we're doing is creating a pool of money to be used if care is needed. So if you create a pool of funds of 250,000 and your expenses are 300,000, you have out-of-pocket expense.
Yes.
You can buy lifetime coverage. Most people do not today, but you certainly can do that.
Can do that. And the other thing I wanted to quantify was, when you say most expensive way, let me make sure I understand, because people will often look at the premiums and think, oh, that's expensive. But I think what you're saying is if I needed care, and I don't know if it's maybe you're saying like based on an average stay, if I actually needed care, one of the most expensive ways for me to pay for it would be to self-fund. That would end up costing me more than if I would have paid these premiums along the way. Is that an accurate description of what you mean by most expensive? Okay.
Right.
Yep. I like that way of looking at it, because it's, some people look at just the premium and that's what they think of as the cost, but you're looking at, no, let's look at the actual cost of care. And if you need it, what would be the most efficient way to pay for it?
Right.
Right. What about number 4, buying into continuing care communities? What are some of the risks? What do you see there?
Let me just mention to you that my battery is running low and I might disappear. So
if so, we'll fix it. Do you have a plug with you?
I don't.
Okay.
Okay. So continuing care retirement communities, I'm going to suggest that they are self-funding. There are 3 different types. Type A, B, and C. And type A are typically the ones that you pay a significant entry fee, and care is provided. Type B and C operate more like assisted living.
Uh-oh. I wonder if we've lost her. Derek, Mike, is she frozen for you guys?
That might be it.
Yep. Okay. I know I can hear her in the other room, so I know she's still talking. I can. You want to step up here and use my mic to answer requests? Oh, okay.
So sorry. So sorry. I thought I had plenty of battery. The type A, type B and C operate more like assisted living communities where there's a monthly charge. The thing that I think is critically important with continuing care retirement communities is that you must read the contract carefully to understand how long-term care is provided. Who makes the decision? What if the assisted living facility is booked? Where do you go then? Think of an assisted living community within a continuing care retirement community as a small hotel. If all the rooms are taken and you need care, where are you going to go? So it's just, I've read a number of these contracts, and they make me nervous. So be very careful if you're looking at a continuing care retirement community that you understand how long-term care will be provided. And then the last thing we've talked about this is that, now we've talked about kids paying for care, but yeah, a lot of kids have done very well and they can afford to pay for parents' premiums. Others not so much, and so the kids have shared the premiums for their parents because they realize how important the insurance is, not only for their parents but also for themselves. Okay. The cost of long-term care, the Medicaid budget in most states' budget is the fastest growing line item. And that is why we are seeing states exploring a tax for long-term care. Now, Washington State has implemented Washington CARES Act. It was actually to go into effect on January 1st of 2022. It just went into effect July of this year, and that's because there were so many flaws in the way it worked. But basically, it will tax a W-2 employee. It will tax 0.58% forever, for as long as you work. The benefit amount is $36,500. That's not going to go very far. And but what we're seeing now, if you look at the purple on this map, these are states that are seriously exploring putting their own system in place. And so we'll see. We'll see what happens. But the cost of long-term care in the country has been a big deal for a long, long time.
Thank you. Technology problem solved by all being in the same place. I know we're running long, and so we are wrapping up, but we are going to take questions and answers in a minute. But this is a short timeline of what to do. Create a timeline of expenses. You know, we definitely advise that you get professional advice. You want to evaluate your options each year. Medicare open enrollment and healthcare.gov open enrollment is starting soon. Derek, Mike, I'm going to ask each one of you, is there one quick one-line action that you would recommend people take? Derek, go ahead.
Get your plan reviewed. You know, if you're on Medicare, it's a very simple way to spend more than you need to. Also, too, things change every year. So get your plan reviewed every year. Contact somebody. Don't be someone who, you know, 10 years down the road says, hey, now I want to get reviewed, and you're paying $200 more per month, and you really needed to on, you know, the premium of maybe a plan, and then the drug plan as well can be expensive. So get
your plan reviewed. Mike, you?
Yes, I would definitely second what Derek said. And in addition to that is maybe think very critically about the choices you make and how your insurance dollars are being used. A lot of times people are scared of big deductibles because they think, you know, that's just going to bankrupt me in some way. But that's where you want to sit down with someone like Derek and I, you know, definitely go through your options, make sure you understand what's at risk, and make sure you're actually not overspending on healthcare.
Love it. Well, as we always do at the end of our webinars, we are going to open it up for Q&A, but we're probably going to cap that Q&A to about 20, no more than 30 minutes. So it is 6:30 p.m. Our introducer, Bob Powell, will come back on the line, I believe, here in a moment and help us with the Q&A. And he is on East Coast time. So it is now 8:30 p.m. and we want to make sure he gets a good night's sleep. So I have seen questions rolling in here. I have everyone's contact information up on the slide. I'm on this last slide, and I'm going to leave it up there while we're doing Q&A. So if there's questions we don't get to, you can reach out to them directly. You can send us your questions at info@sensiblemoney.com. And while we do not share your information with any of our outside vendors, what we may do is if there's questions that we see that come in that we don't get answered, we may farm those specific questions and your email address out to either Derek, Mike, or Nicole specifically to get that answered for you. So with that being said, Bob, welcome back. I know you've been seeing the questions roll in. Where do you want to start?
Well, there's a lot. And just for a point of clarification, it's 9:30 on the East Coast.
Oh, goodness, you're right. I forget that Arizona, we don't change times. It's 9:30. Oh, my gosh, thank you.
You're welcome. All right, so I'm going to start. I think here's one question I begin with. It's I understand that there are 3 types of Medigap premiums: attained age, issue age, and community rated. Could you explain those?
I can take that one too.
Go ahead.
Yeah, so basically in certain states, certain plans, attained age doesn't exist in Arizona. It's not a thing. But issue age is basically you're going to get the rate assigned to you for the age that you take the policy out. Any future increases are going to be based on medical inflation solely. The attained age aspect is you're going to get a little bit of an increase every year because of you being slightly older as well as medical inflation. And then community rated plans, very similar to issue age. A lot of times, just in practicality, what I see when people are looking at those types of policies is it's fundamentally sort of like an issue age policy, but there's oftentimes an enrollment discount associated with it. So it sort of mimics an age-related adjustment. You might get an additional 3% every year until a set age. It's not infinite like attained age, you know, maybe to 80 or 83, and then it's just flat again. But so it's just based on really your either issue age is that's what you get, medical inflation, attained age, community rated, very similar medical inflation, age-related adjustment every year.
I'm retired with a defined benefit pension plan plus income streams from various investments. Is there a way I can get the tax benefit of an HSA?
If you're retired, well, my understanding is you have to have a HSA plan, a high deductible plan that is HSA eligible. So if you're already on Medicare, the answer would be no. If you're under Medicare, it would depend on if you have an HSA eligible plan or can find one. Mike, does that sound right?
Yes, that's completely correct. And actually, there are HSA eligible plans available through the ACA in the marketplace, as well as there's a few individually underwritten plans that now have an HSA qualifying component as well.
Yeah, well, just to follow up to that last question, if that person is enrolled in Medicare, then they would not be able to?
No, you don't want to do that unless you want to pay some taxes.
Right. Okay, let's see. Nevada has what they call a birthday rule. The month of your birthday, you're allowed to change your supplemental plan. And also guaranteed issue. Can you explain how the birthday rule works?
Yes. So basically, there are certain states in the country now that provided that you were on a Medicare supplement, every year around your birthday, you get the option of choosing a new Medicare supplement. You get to go out and shop, and it's guaranteed issue, meaning there are no health questions asked, and you get to basically pick a new policy regardless of your health. You can change any time of the year through underwriting, but it's a safe bet. You know, if you have issues, you can always shop around your birthday.
And there are a growing number of states that are offering this opportunity, right? I think Massachusetts, Minnesota.
Yeah, Illinois has a sort of, it's a birthday rule to a point. I can't remember what age it caps out at, but California is a big one. They have a birthday rule as well. I feel like maybe, you know, in the future, we're going to see more states adopting, you know, that sort of legislation.
Another question. I am now 64. I plan on working until age 66. Should I still apply for Medicare at age 65 if I plan on obtaining COBRA for my wife after retirement, as she is 18 months younger than me? I have read about a COBRA trap and not sure what that means.
So yes, I just had this situation this week. A gentleman going on to Medicare, his trailing spouse, so actually more than 18 months behind him, but you just have to make sure. A lot of times there is a COBRA option. I would urge you to talk to your benefits coordinator through your employer. That's going back to that chart where we talked about, you know, looking at a COBRA availability. This gentleman is now on Medicare as of actually October 1st. His spouse will be going on to the same group plan she had, even though she was not the employee, for 18 months. So she's going to be just fine from there. So yes, you just have to kind of explore the nuance of it, make sure it's an option, but it's kind of, don't leave that stone unturned.
Next question is, how do you make sure the coverage is creditable for Medicare?
So basically you, again, quick litmus test, 20 or more employees, but you can also get a creditable coverage letter. You can ask your HR department if your coverage is creditable. If you kind of feel like you don't get a confident answer, you know, maybe dig a little bit deeper in with the insurance company and see what they can do to provide clarification.
Are there off exchange plans going to only 4 months of duration?
Yes, there are off exchange plans that can be as short as 1 month if you needed just 1 month of coverage.
Can I get an ACA plan with lower MOOP if I have low taxable income?
Yes, that is correct. So there is a component of these plans now, in addition to premium tax credits. If your income is at a low enough point, you get what's called a cost sharing reduction, and it will actually lower your copays, deductibles, and any other out-of-pockets.
Dana, you're back. So there was a question, Dana, about the formula regarding AGI and not taxable Social Security. Could you just go through that again?
Yeah, so it's adjusted gross income, which typically you find on your tax return toward the bottom of the first page. And then you add back the non-taxable portion of Social Security. And then you add any tax-free interest. Usually you would have that if you had any municipal bonds in your portfolio. And then you have to add back any untaxed foreign income. Most people we work with don't have that, but that is part of the modified adjusted gross income definition when they're looking at what percentage of the healthcare premium would you pay. So they talk about percentage of income. Well, how do they define income? By that formula of modified adjusted gross income.
Yeah, and at one point, one of the attendees thought she heard you to say withdrawal from savings equals income.
No. A withdrawal from savings does not count in that formula. And so, you know, that would be a withdrawal from like a bank savings account, right? With a bank savings account, you get a 1099 and you report any interest income each year. But if you just take a withdrawal, you know, you take $5,000 out of your savings account, that's not taxable income reported on your tax return. However, since we're using the word savings can be rather broadly defined, let's say you had a portfolio of mutual funds or stocks and you take a withdrawal. Well, when you sell those stocks or those mutual funds, there may be a capital gains tax that comes in. On the same side, if you took a withdrawal from IRAs, because some people might define that as savings, well, your IRA withdrawal will completely count as taxable income in that formula.
Question goes like this: something I've never understood, and perhaps someone here knows the answer. Why can't Medicare supplement premiums be paid from an HSA?
That's actually a pretty good question. I've always just advised don't do it. I think it's because the actual Medicare supplement, it's just a private insurance agreement, so it's not actually a Medicare. That, you know, there's no federal subsidies involved with it. Therefore, you know, That's a hunch I have. It's not fact, but I think that's
Yeah,
why.
I'd say because the government says so. They make the rules. I don't, it's a great question, but I don't know the logic behind it. But that answer sounds good to me, Mike.
Yeah, that's the only thing I can think of after looking at this for a long time.
At age 65, what Medicare plan would be best to cover cancer care?
So really, I mean, on original Medicare, you're going to have access to a lot of facilities. And if you were actively undergoing cancer treatment, you might have lower out of pockets there. So that's always an analysis that we want to help with. I've done that many times, but just a standard Medicare supplement type Plan G and original Medicare would effectively cap your costs at $226 for this year. Chemotherapy is actually a Part B benefit. It's not a Part D benefit. So that's really how we see those costs explode, but it's capped by the insurance.
If I heard correctly, the tax qualified plan premiums for long-term care policies are deductible. If that is the case, would there be any benefit to using HSA funds to pay the premium?
Nicole, obviously not back on, but I want to qualify that. We may have to follow up and address that question because I believe it's only a portion of the long-term care premiums that may be deductible. So if I remember right, at some point she had showed me a chart that said like, here would be the maximum amount that could be taken as a deduction. So I think it could be that part of it could be deductible and the rest could potentially be paid out of the HSA. But we'll flag that question and make sure that I'm answering correctly and clarify it with you. And then what we do is when we post this to YouTube, if there's anything we said that needed clarification, we'll add it to the comments.
Does the ACA credit true up on the 1040 go in both directions? In other words, will you get a refund if you underestimated the credits due?
Yes, absolutely, 100%. I actually sometimes, if somebody's a little unsure of what to put down as their expected income, I tell them overshoot it, so you actually do get a refund rather than a surprise.
Great. Is there a underpayment penalty if you materially overestimated your ACA credits?
If you no, it's just, again, it goes back to that thing of worst case scenario, you pay the full retail value of the ACA plan, which is a stated dollar amount that you would see during the application process.
I just got to clarify. I think that person may be kind of hinting at a strategy where you borrow from the government, right? You could say, well, I got to keep my money and earn interest on it. And then at the end, I file my tax return and there's no penalty. So I just pay up whatever the difference is. So
yeah,
could you do that?
Well, you could, but you're definitely going to balance it out at the end of the year. I don't advise doing it. You want to be accurate with your projections to the best of your knowledge.
Regarding the use of HSA funds, if only one spouse has had a high deductible policy and HSA pre-65, can the funds be used for either spouse's medical costs once both are enrolled in Medicare?
You know that, Mike? I don't have a real confident answer on this, but I think this question came up before, and I think there are cases where you can pay benefits for a spouse out of your HSA, but I don't know that for sure.
I have had this question too. I think what you're saying is true. I would say I would definitely want to do a little bit more of a deep dive into the tax code and everything like that, just to make sure, and obviously, consult a tax professional about that.
Yeah, I'm writing that one down also as something we can follow up on.
Next question, if I'm eligible for Part A, having worked for a large corporation full-time for 30 plus years, but my wife has not worked, will she have to pay for Part A?
No, she actually will not. This is something that's going to be very helpful to this individual. You'll want to schedule this out, but you can actually have your spouse, provided that you've been married for X number of years and they meet certain criteria, sounds like that would fit the bill. They can get Medicare based on your work record. I've actually helped people do that before.
For Derek, is it wise for an individual that's fully covered through the VA to refuse parts B and D?
Derek's sound isn't
Oh,
working, but
Derek.
he's
Oh, can you
shaking his
hear it?
head
All right,
no.
we'll have to, all right.
Derek, if
Yeah.
there's anything you want to qualify to, you can chat to us in the chat box, and then we can read off your answer.
Let's see.
Mike, you were going to say something about.
Oh, yeah, I was just going to say that the VA itself is not health insurance. It's not creditable coverage. It's a benefit, so basically you have medical care at the VA. I advise people, and the VA will advise people that have that option to take A and B so that they can seek care outside of the VA once they're on Medicare.
Let's see. Sorry, I've got to scroll down a little bit. There's so many.
I know there's so many questions, so many. I can see them too.
Yeah. Let's see. Bear with me a second.
I see one. Can you sign up for Medicare via Social Security website, or is there a Medicare website to sign up? Mike?
Yeah, so I know Derek knows all these answers, so I'm waiting to see
know
if
he does.
he comes back on. But yes, that's actually the way you would want to do it. You could call in to do it. Pretty much when Derek and I help people with Medicare enrollment, we're always going through the SSA.gov portal. We tell everybody the hardest part is really navigating the website. It's not the application, so half the time is spent doing that.
Here's one. When you are on Medicare, you are not on a high deductible plan, so therefore not eligible for HSA. But why do you need to stop HSA before Medicare starts?
Because to contribute to an HSA, you need to be on a high deductible health plan, and Medicare is technically not a high deductible health plan.
Another one of those, the government set the rules.
Even though if you think about it, Medicare is the highest of high deductible just by itself, but it does not count. Do not do it.
We had one attendee who said, I'm confused. What is the difference? Can you explain again the difference between a supplement and an advantage plan?
Yeah, so a supplement complements your original Medicare, very high level. When you take an advantage plan, you assign your Medicare benefits to an insurance company.
And I'll qualify that. They are two separate ways of getting supplemental care when you are on Medicare, and they are mutually exclusive. You don't have both. So
Yeah.
You either add the supplement plan or you add an advantage plan. And as Mike just described, they work differently, but it is confusing, and I understand why someone would ask the question.
Yeah, and I tell everybody very simply, original Medicare is going to be fee for service. So it's just like Derek said earlier in the presentation, if your doctor orders that, there's a code associated with it, there's a Medicare approved rate, there's no prior authorization for it. Once you go to the advantage side, you're going to have prior authorization and things like that. So it's a lot like that HMO or the PPO that you have, just like Derek said earlier.
Yeah. How do I find a reputable group like ASC Insurance in my home state of Texas?
Well, I mean, we do work in Texas. Both Derek and I are licensed in Texas and have clients there, so be happy to help you. But I tell everybody, just seek out a broker, have a conversation. If it seems like a good fit and you think you can have a trusted relationship with them, it's going to be a good deal for you.
Can you speak to a pharmacy plan that involves a LTC pharmacy? There seems to be no way to shop.
I would have to know, are they talking about as if somebody has, if they're in a long-term care facility and they have a drug plan?
It's not quite clear from the question.
Yeah, I would have to have a little bit more information.
Okay. If your employment ends suddenly and you have been making HSA contributions, is there an exception from penalties or taxes?
No. So it's just going to be something that you have to deal with. It actually becomes a tax problem as far as I know. Does that sound right to you, Dana, if you did have some overlap there? Maybe.
So read the question. You have been making HSA contributions. So if your employment ends, that's a great question. Your coverage might not necessarily end. So I think what they're assuming is I'm on a high deductible plan through my employer, my employment ends, and my coverage ends. And the question, you could have fully funded your HSA at the beginning of the year, and are you now eligible to do that, or did you overfund it?
Yeah.
That's another great question.
So I think what they're talking about in that question is if you hadn't signed up for Part A and all of a sudden you did have to sign up for Medicare, there is that 6-month, retroactive Part A coverage. And that would actually be 6 months prior to the date of your actual Medicare application. So it's not the date that Medicare starts, it's the date of your application. 6 months prior to that is when your Part A would start. So you would potentially have some overlap. But again, that's something you can deal with through taxes. I actually had a client that actually had this, and I believe he was able to sort of forfeit the HSA contributions and go back, but he had to work that out with his accountant.
Maybe this is a question for Nicole, but maybe you, Dana, too. Can you run scenarios on crossover points for self-funding long-term care costs versus hybrid or traditional insurance products?
I can, and we do, but I wouldn't define it as a crossover point. So as part of our planning process, we will do a projection that says, if you needed 5 years of care, and today let's assume it's $300 a day, but we're going to inflate it by 5%, what would it cost at the time of a typical onset of care, let's say in your early 80s? And what assets are we projecting you would have available at that point to meet that cost, and how long would it last? And so that is a projection that we do. At the same time, we find that many people who maybe we would run that projection and they would say, yeah, great, I can self-fund, right? I can pay for this out of pocket if it happens. There are some other advantages to having insurance, and a lot of those have been proven that people who have it tend to get care and a higher quality of care, versus there can be that tendency to, I don't have insurance, I'm just gonna, make do. And so we have found one of our own planners, actually, her parents live in Florida. She is in Massachusetts. Unfortunately, she's had to go back to Florida multiple times recently. Her parents had to go to care. And it has just been so draining and exhausting, and they have insurance. And she was just saying how much it has changed her perspective, even for well-off clients, on the benefits of having insurance at that stage and the quality of care that you can get when you're going around and interviewing different places. So yes, we can run that type of analysis, and I would just say I don't think that's the only factor to consider. I think there's more to it.
My mom had a long-term care insurance policy that included home care. Medical companies would say it wasn't worth triggering her benefits, even though she qualified for care. Home health kept saying how bad the policies in general were and not worth paying for the initial 90 days. The information turned out to be false. Her plan should have been triggered sooner. This was a traditional plan and my mom had care at home. Is this typical to have medical people dismissing your long-term care plan?
Ooh. That's a great question. I don't think that's typical. I will run this question by Nicole and we'll follow up with you. I don't think that's typical. I have certainly seen clients with long-term care policies, get benefits. At the same time, we've all had situations with various service people from any industry where we got misinformation. I hate that term. It's all over the misinformation. I got to use some other, some other term now. That's too charged of a term. But, even from Social Security, right? We've had people call, and it's not that someone was trying to intentionally deceive them. They were given false information. It wasn't accurate. And so, no, I don't think that's typical. And it's unfortunate that happened, but I will run that by and see if Nicole sees that very often.
Yeah. Can you comment on the Genworth long-term care cost calculator to get an estimate of LTC costs in your area?
I can't. I can go grab Nicole, though, if you want me to. Hold on a second. You ask a few more questions and I'll go see if I can find her. But
I can at least take a quick stab at it, which is they do that survey annually and they track home health aides, they track long-term care facilities like assisted living and nursing homes, semi-private rooms, private rooms, and I know many people do refer to that as a fairly good source for average costs in a particular state. But I'll let Nicole take that one. Nicole, the question was, can you comment on the Genworth long-term care cost calculator to get an estimate of LTC costs in your area?
Yes, and it's fabulous. You can put in where you live. It will give you the closest area to where you live, and then you can project out. Let's say you're 60 and you want to know what the price will be, what the cost will be when you're 80. And so you can say, tell me the costs in 2043. And you can also adjust the cost of care by 3%, 4%, 5%. It's a fabulous, it's fabulous, and you can actually compare costs. If you're thinking of retiring to another place, look at where you live, look at where you would be retiring.
Nicole, keep the headphones on for a second. I've recently spoken.
Go.
Oh,
we're sharing a microphone here.
I've recently spoken with a broker for long-term care insurance and was told that underwriting has become increasingly difficult. I'm in Ohio. Can you speak to this topic?
Underwriting changes all the time, and it has become very difficult. I sometimes wonder if people are not applying because they know they're going to need it. I mean, I probably, when I first started, I think I might have had 10% of my cases declined, and it's probably more like 50% now.
Nicole, just to follow up, when someone does get declined, is it near impossible for them to apply to another provider?
No. What we do in our process is we have 3 steps. The first step is a detailed health history. Then we do an educational meeting and then go to application. With the health history questionnaire, if I'm concerned that a client is not insurable, I will have a pre-screening consultation with the carrier underwriter. And they will say, yeah, you've got a green light, or they'll say, we need this information, or this case would be rated. And I'll shop. But for the carrier where we will have the best opportunity to place the policy. But there are a couple of carriers that are very good in terms of insuring people who have been declined by other carriers, and so we do have backup, and they have said, bring us your declines. They do have to be authorized by an application. Doesn't mean a policy issue, but an application then is reviewed by the medical director, so that we're not just submitting another decline.
So a similar question perhaps for you, Mike, is for someone who switches from Medicare Advantage to Medigap but gets declined, the possibility of them getting approved by another Medigap company is unlikely?
Not always. I mean, it depends on, just like in what Nicole was describing, different carriers have different criteria. I actually sometimes do a pre-screening just by asking the questions. You quickly kind of get a sense of whether it can go or not. And, I encourage everybody to, let's talk about it. we'll figure out a good fit if you really want to make that change.
Yeah, sorry, that was moderator's prerogative on that one.
Bob,
But-
I know we are at 10 o'clock your time, and so I'm going to cap our questions. I know there's so many that didn't get answered. I see one, will a broker have all the Medicare supplement plans that are available in my state? Is that a quick yes or no answer, Mike?
We can see them all.
You can see them all. Okay, so
We'll have an open
interesting.
conversation about it, yes.
Yep. I know all of the people that joined us tonight, their email addresses are on the screen. They would be happy to address your questions. So whether they're specific to long-term care or health insurance, you know, they've all agreed if you reach out, they're not gonna shove anything down your throat. That's not how we are. It's not our style, none of us, but they will be more than happy to answer your questions. And so we're also gonna follow up and make sure that we try to get them all answered. I'm not gonna guarantee it because there's a lot of them, but we are gonna do our best. So with that, there's still a substantial number of people who have stayed all the way here to the end. Thank you very much. We appreciate you taking time out of your Thursday night. Thank you, Nicole. Thank you, Bob. Thank you, Mike. Thank you, Derek. And we will hopefully see you on a webinar again. Good night, everybody.